See, the recent concept in the management of varicose vein, the development of varicose veins, and the main newer methodology that has come in the treatment have all been discussed now. And venous disorders are partly only varicose vein. There are enough number of more varicose veins. Apart from varicose veins, we have many venous disorders, and the time only can tell you whether you can read the whole thing. This day is dedicated to Chandramohan. I think Chandramohan was with us, a colleague of us, and I was in one of the meetings. You can see Chandramohan along with the rest of the surgeon gastroenterologists there. Ardhanari and Professor N.R. are there, and Chandramohan is there on the other end. Next. See, we know that it is William Harvey who said the blood circulates. And it took a long of time to accept the fact that blood is circulating. But finally they came to the conclusion that blood circulates in the body. And it is now found the cause of varicose vein is postural and gravitational forces. There is another controversy in varicose vein. The Saphenous etymology, if you see Saphenous vein, 90% of the ancient European names were Saphenous is meaning evident, but the rest of the books also are given Ephena meaning concealed. Totally exactly opposite nomenclature has been given. The origin of the name has been attributed to Greek deviation of Saphenous meaning evident, as well as an Arabic conversation, Avicenna, of the term concealed. So it can either be, but later newer English textbooks have got it as only Saphenous vein. And when you are presenting, it is one of the bugbears for the final year MBBS students and junior postgraduates. When the word dilated, elongated, tortuous veins, this is what the examiner expects. You have to say what is that varicose vein? Dilated, elongated, tortuous vein. And if you go by history, you see they have been used to have frequent wars, and people have been very good in ligating bleeding veins. And there is another sculpture that in serpentine windings are not to be operated upon because they would mean dead on the ground. That means you will not survive. Don't operate on varicose veins. That is what the Stone Age sculpture says. So there are two aspects. The basic thing that happens in circulation is your artery and vein. An artery and vein, if you see an artery cut open and see this as you are dissecting, it contains three layers: tunica albuginea, tunica intima. The intima is peeled off. Now we are seeing that artery forceps is trying to take out the intimal flap. You have the vein on the left side, the vein having a bicuspid valve that helps pushing the blood from foot to the heart. And the structure of venous valve reflects in 80% of the venous diseases. You analyze any of the venous diseases, a component of reflex of the valve will always be there. And chronic venous insufficiency, CVI, and this is the main ankle perforator causing lipodermosclerosis. You find ulcers, lipodermosclerosis, lipomatosis, skin infection, fibrosis, sclerosis, lipodermosclerosis. The mid-thigh perforator is also an enigma. It starts in the popliteal fossa, goes up from below upwards, and goes to the saphenous vein. From short saphenous vein, there are a lot of controversies in the management of short saphenous because the main posterior leg vein is close to the opening of the popliteal fascia, but short saphenous vein doesn't come and join there. Only 60% of them join the popliteal vein, 20% of them in the long saphenous vein via a posterior midline or anterior lateral veins. 20% of the joints saphenous vein and the dorsal foot veins. There are types of perforators. So I'm describing only the perforators. Reflexing saphenous vein perforators. It is a very simple thing, from the subcutaneous tissue to the skin. Then from the deep vein to the thing about the reflexing vein, and type 3 is mixed variety, and type 4 is part of collaterals. It can have a collateral continuing to the muscle veins, and muscle on to reflexing vein, reflexing on to reflexing one type subcutaneous, or you can have an isolated perforator. As you see in a Linton procedure, there is a subfacial line, and everything corrects there in the thing. That is an isolated perforator. We name it as type 5. So there are 5 types of perforators. And as you've seen, the nomenclature keeps changing. Earlier it was Hunter's perforator. John Hunter, you must have heard, the Hunter's canal is the first dissection in the anatomy class. We have the subsartorial canal, where you got the artery comes and goes from anterior to posterior. The veins, you have the Hunter and Dodd, where the thigh perforators. Boyd's perforators is just below the knee, infragenicular perforators. And you have got the Cockett and 246, that is what the re-nomenclature done. Cockett 1, 2, 3 is 246. There is one other new nomenclature. Do away with all the names, give numbers. Like whatever car registration number, keep changing. Foot, ankle, leg, knee, thigh, and gluteal. For major perforator in and around. Then you have the main thing that worries women is cosmetic aspect of varicose vein, and they would like to have a surgery and end up with a scarring in the subcutaneous tissue. Telangiectasias, reticular varices, truncular varices. So these are all called as minor varices. It has to be tackled by local short bursts of lasers and cosmetic thing with the dermatologist. Nothing else is required, it doesn't give complications, stays on and on. This is the main culprit. In all situations, people are thinking it is the long saphenous vein. There is, and the medial malleolus anterior, medial malleolus anterior to it, and communicated with the long saphenous vein. And there's one posterior arch vein which is behind it. It arises at the knee level, goes posterior, and reconnects at the saphenous vein. So how does it start? It starts posterior arch vein at below the knee, and you have the hemocytosis pigments. They start pigmenting in the leg level, and the leg level pigmentation is obvious on the right side, and they develop varicose vein subsequently. And the type of venous disease. Now that you know there is a vein, there is an artery, and the vein has got complications, perforators. The main thing is varicose vein, which because of their profession. Venous ulcer is acquired and a congenital component. Deep vein thrombosis is also acquired and thrombosis. So congenital causes of blood coagulation. See, the blood has to flow, the blood has to be thick, it should be turbulent, 3/4. Chronic venous insufficiency is an acquired disease. Vascular malformation is a congenital condition where you have various varieties of hemangiomas, which is the word used by so many years, been removed. Now it is called as vascular malformations. And congenital vascular diseases producing deformities is KT, crippled Trendelenburg syndrome, is a congenital malformation. Post-DVT, primary versus secondary varicose vein. I told you long saphenous vein and short saphenous system, primarily affecting the long saphenous and without any subdivisions, without going on to the deep veins is a post-DVT secondary varicose vein. AV malformation, because the volume of blood flowing, you get varicose veins. It should not be operated. AV obstruction, IV obstruction. We have obstruction at the iliac level due to thrombophlebitis, where you have the gluteal veins. Then you have the renal vein thrombosis producing problems. Then you have the hepatic level, you have the diaphragmatic level, you have block, you have got the Budd-Chiari syndromes and all that. And venous malformations, apart from KT syndrome, there is Klippel-Trenaunay syndrome. You have a May-Turner syndrome. I think last class we told about May-Turner syndrome, which is the left common iliac artery pressing on the right common iliac artery pressing on the left common iliac vein and producing venous varicosities. Maffucci syndromes and Weber syndromes are congenital conditions which produces vascular malformation. KT syndrome is now renamed as CLVM because the WHO said it is anatomical, capillary lymphatics, veins and malformation. It is the axis vein. Every limb has got an axis vein. Preaxial, postaxial is what they describe. You have the embryological malformation of the axis veins. So you have the inner axial vein in the upper limb, outer axial vein in the left, in the lower limb are important. Three main symptoms: varicosities, hemangiomas, extremity hypertrophy. You have like anything like hemangiomas and varicosities. Apart from that, you have got the limb not equal. Veins along the lateral aspects of the limb. And there was Weber syndrome. The second man is Trendelenburg. His name has been there in thoracic surgery. His name is in orthopedics. His name is in general surgery. Varicoses. He is Trendelenburg. And this is Klippel-Trenaunay syndrome. See, all this I put it in the presentation so that at least this half of the names will forget, but the disease will remember. The lateral side of the limb, you have a big venous line that is called as the axial vein that is present in Klippel-Trenaunay, the diagnostic. Varicose veins, common surgical pathology. Now we come to the varicose vein, which most of the people see in the examination. Varicose veins, common surgical pathology in 25% to 40% of the individual. We told you about superficial system from the thigh, deep system from the leg, deep venous reflex, calf muscle failure, and deep veins thrombosis. But this test is useful for TVT. I will come to that. This arrow says normally blood should go from ankle to the heart, right area. But it is now trying to come down and gets alternate circulation, then come back to the calf muscle, a recircle phenomenon, which results in a formation of edema and dilatation of the veins. The vein, once it dilates, even if it is a superficial system, long saphenous or short saphenous, once it dilates, the check valve becomes bad. So the valve is no longer functional because it widens, it doesn't occlude. So vertical forces and lateral forces are the two types of vertical load and lateral forces in the varicose veins. Anything from above downwards, we call it as the vertical forces. Anything across the deep vein to the subcutaneous superficial vein, we call it as the lateral forces. All the type of perforators are all lateral forces. So clinical examination will see the management of varicose veins as clinical examination, complications, conservative methods used, correct surgical management, and correct options available. There is enough number of clinical tests. See, discussing about Graves' disease, we had for thyroid, there are about 42 eponyms. We desire to forget it, and we'll at least know it because these are all the tests which are asked in the exam, which like Brody Trendelenburg, Schwartz test, Perthes test, Oshner 3-bandage test, and Pratt's test, and all these tests has to be done in the examination. The 3-bandage test, the Trendelenburg 1 and 2 test, and Perthes test are the 3 things that are done. Perthes test is dorsiflexion and compression of the calf muscle produces pain. And Mehron Oshner test, where you have 3 bandages tied, one to prevent Trendelenburg level the blood from the Saphenous vein coming in, and the other one from below to find out any regional perforators. That is called as the Oshner test. And Trendelenburg test is predominantly done to know whether the saphenofemoral junction is incompetent or competent. Any flow more than normal will dilate and reflex will also be more. So, clinical tests and signs of varicose vein, it's a common feature in the examination. And you can see if somebody given a case of a varicose vein, he is really scared. He goes here and there, gets for a bandage, runs around. CEAP classification is the clinical, etiological, anatomical, and pathological. It's been very religiously followed. Apart from the C1, C0 to C6, 7 clinicological classification, because clinical is important. Etiological, anatomical, pathological. And this is a very important study which they have done a validation study for all these veins. They have told you the bandages across the thigh, bandages above the knee, bandages below the knee, 3 bandages, all that are inaccurate. Textbooks of the courses should be revised and replace these tests with how to use handheld Doppler. See, so with the use of handheld Doppler, which is now ubiquitous in the vascular surgery department, it is clinical examination with varicose when you use a Doppler, which can be done as an office procedure. This is a validation study by Kim in the AR Royal College Surgery study. I think it was a meta-analysis. What are all the complications of varicose vein? So making a diagnosis is easy, but you have to look for complications. Equinus deformity. You see the ankle joint is now plantar flex. You have the equinus deformity, very common. It gets fixed. The ulcer gets adherent to the bone, and it is called as equinus deformity of varicose vein. Phleboliths. Stones can form impregnated in the subcutaneous tissue, produce periostitis and abscesses, recurrent sinuses. Venous ulcers are one thing which is very difficult to maintain because people don't comply. And Bisgard's line of management is strict, keeping him a 3-layer bandage or 4-layer bandage and make him lie down. He is a hypodermosclerosis and venous ulcers and all the complications of varicose vein. It can be phlebitis. This is another important thing you should know about phlebitis. Subcutaneous veins, if they are inflamed, you call it as phlebothrombosis and thrombophlebitis. When it occurs in the subcutaneous tissue, it is called as thrombophlebitis. When it occurs in the deep veins, it is called as phlebothrombosis. And pigmentations are all because of the hemosiderin coming into the subcutaneous tissue, and also there are a lot of theories we see. That is what I was saying. The fibrin cuff theory and WBC trapping theory produces leukodermosclerosis. But the underlying pathology, we should have an underlying venous hypertension, ambulatory or otherwise. Ambulatory venous hypertension decreases lymphatic drainage, white cell trapping, macromolecules enter the circulation, produce a pericapillary fibrin cuff, impaired tissue perfusion and oxygen. This is the theory aspect of varicose vein. Ambulatory hypertension is there, Lymphatic drainage must be decreased because of fibrosis, blood cell trapping, or pericapillary fibrin cuff develops and produces one occurring earlier, one occurring later, whichever occurs initiates the ulcer formation. This is your champagne bottle, atrophy blanche. This is very typical of deep vein thrombosis and chronic leg, where it becomes lower half at the gaiter area, what we call it as the gaiter area, GAITER. And the gaiter area produces constriction of lower one-third of the leg. And that stands out like a beer bottle. We call it as atrophy blanche. And naturally the circulation goes and the patient develops more and more ulcer with less and less complaints. Then how do you diagnose any end, diagnostic end? You have got the diagnostic levels. Clinical, I told you, level 1, handheld Doppler. Then duplex scan and the augmented venous pressure are the easiest thing. Then the MRVs and venographies and CEXTs are done for major venous obstructions. Can anybody say me who is this gentleman? Somebody? He is Doppler, who invented the Doppler, Strandus and Doppler. We described the phenomenon of Doppler. You have the normal arteries, artery are red going away, and veins towards the lower limb. It's called as normal arterial tibial artery flow will be like this, augmented flow and squeezing the calf muscle. When you squeeze the calf muscle, you get the popliteal vein has an augmented supply. You get a burst, what we call it as augmented flow popliteal vein. The same thing you can see in the other side, the varicose vein joining the common facial vein joining the saphenous vein, you have a dilatation and reflex. It's very clear. A big dilated saphenous vein. Duplex scan is what is done for major artery and veins is the abdominal level. Then conservative methods. Graded compression stockings, the range of ankle pressures. You have class 1 to class 4. Class 2 is 25 to 35 millimeters. Whatever material you use, class 2 is compression amount, pressure has to be applied. Class 2 compression exerting pressures between 18 to 24 is ideal. You have one thing in the patient's consent. Before surgery, during surgery, after surgery, he has to wear compression bandages, which they are resent. Now they think that once surgery is over, there is no need for a bandage and all that. Bandage and prophylactic thing must and has to be lifelong. Newer method. We have foams, Trivex, venous, and endovenous laser surgeries, then radio frequencies, ablation are all used. Sclerotherapy agents that are used, this is for the exam. The sclerotherapy these things that are commonly used are sodium maruvate, sodium tetratecyl sulfate, polydecanol, ethanolamine, hypertonic saline dextrose, sodium salicylate. So many sclerotherapy agents are available. Like what you do it for esophageal varices, you can use it for lymphangiomas, hemangiomas, and varicose veins. Era of open surgery for varicose vein is going. Era of endovenous technique starts. Endodermal procedures, the simple procedure is you have a sclerosant or a heat or a laser or a radio frequency ablation. It goes inside the place where you want to do it. Cover the entire thing outside cold because of the tumescent fluid and burn the intima which closes by itself. This is how it is done. The principle is the same. Varicose laser ablation therapy. Okay. Video is not functional. Not the file. See, there is an article, European Journal of Vascular Surgery. It is a meta-analysis again. The class has shown there is comparison of sclerosants with regular open surgery. Shown how commonly the varicose veins occur 5 years after apparently thorough treatment. You have the conventional treatment given, whether it is the newer variety of ablation or open surgery. The first 5 years, after that you evaluate, still there is recurrence. So recurrence rate is about 2% for all the long saphenous vein ablation. See, we identify the saphenofemoral junction. It is very important. Circumflex iliac, we have the pudendal, we have the accessory saphenous vein, you have the superior you ligate the Trendelenburg procedure, completely close high ligation without a gap, because that is very important. What happens when you leave a gap between the vein and the saphenofemoral junction? We'll come to that. See, there is artery will tell you can always have a doubt. You can have a probe and see whether the artery is going there or we are tampering onto the nerve. And the preoperatively it is marked. That is very important. Circumflex, internal iliac, and pudendal. Then Trendelenburg surgery, now what is done is anything from thigh onto the knee joint is removed. Major perforator blowouts are excised, and Trendelenburg surgery is done if required. Why it is not done? Invaginative stripping has been tried to reduce the operative injury. We have left large saphenous, accessory saphenous, and sural nerve are damaged in this myostripper. Myostripper has been discontinued, and I don't think anybody uses it. So this is the principle. Suppose you don't ligate close to the thing, high ligation, as said by everybody. Now you see, there's first A is the normal flow from below upwards along the saphenous vein, and it goes and feeds. If you ligate it, instead of going on to the iliac veins, it goes on to the next to the perforators and all these accessory saphenous, and it goes and worsens the saphenous vein flow. A centimeter of 2 from the end saphenofemoral junction reflex with a more incompetent terminal valve with the great saphenous vein. And this is long neglected saphenous. If suppose somebody has got a varicose vein and you have a thing not operated properly or not operated, you get a bulge because of flow and patient walking and running, producing a varicity, which becomes a big cavity, saphena varix. This is a short note surgery. Surgical excision, hoop phlebotomy. So you have various things below the knee joint up to the ankle, everything is a chaos. You have multiple things. There are 800 blowouts are supposed to be there, and these blowouts can be excised by hoop phlebotomy or surgical excision with a small incision cosmetic. Then comes the leg is the sanctuary of all the perforators. So subfacial perforator ligation, Linton's procedure. This Linton's procedure is what was suggested the midline incision is put from the popliteal fossa to the ankle, completely dissected, and you find the entire subfacial plane will have only the veins. You identify the veins. Because it is painful, it is discontinued. Long posterior subfacial incision to ligate perforators is a bigger punishment than varicose veins. Pocket and dot procedure was from ankle onto the medial malleolus, where you have 3 pocket and dot procedure perforators. So this is little more simple. The great saphenous vein has posterior arch vein as a component, first cousin. It goes posteriorly and goes behind the lateral fibula and goes on to the subfacial compartment and then produces leak and complications. You have this at various levels. You can have a venogram MRI and then evaluate. So you can attack them by ligating at that level. A person developing an ankle gaiter area, you find it is red now. You identify it, allow it to heal. Then the perforator vein is identified by using an access port and using a laparoscopic instrument, which we normally use for a gallbladder and all that, and dissecting forceps. And there is no need for inflating the air inside. You can dissect it, put some saline, and reach that place and ligate it easily. So it's a different angle from what you see. Normally it is on the medial side, so it's a technical difficulty of knee joint coming in the way of your hand. In the ankle perforators are lower 1/3, so it has to go through that place, identify the perforator and ligate it. A different viewpoint. And post-operatively they become all right, and there is a varicosity which can be ligated. See, the scopy shows there is a big vein. This is a very simple procedure for a big vein, because a major saphenofemoral vein perforators are identified and ligated with clips or ligate it and burn it. And you should have idea about polycythemias, thrombocytosis, APA syndromes, protein C and S deficiencies, Leiden factor, homocystinuria, all those things are all friends of vascular surgery. It must be done. Homocysteine levels must be done for all cases stepping into the vascular surgery department. Like atherosclerosis, homocysteine is also one of the causes of coagulation. See, more than about 300-400 papers have been on destroyed veins. You have valvuloplasty for chronic venous infection. So this was suggested by Seshatri Raju of India. Journal articles about 300 on this alone, varicose vein alone, valvuloplasty, he has published. This is simple. Any valve has, as it tries to go and the volume increases, you get dilatation and there is a reflex. The reflex is when the tip of the valve doesn't touch the other side. So you get always associate with the pelvic pathology, find out whether there is any pelvic problem, and evaluate a deep vein thrombosis as well. Recurrence of varicose vein that follows surgery for saphenofemoral junction or saphenopopliteal junction, 20% following primary surgery, and recurrence of emergence of varices. She was this thing. Conservative hemodynamic treatment for incompetent perforators in ambulatory patients. That's what I was telling you. People are steadfast and having everything cleared without any bandage, which is not possible. So conservative hemodynamic treatment for incompetent varicose veins in ambulatory patients is called the Chiva trial. So what are the axioms, you go home message or whatever way you call it? DVTs and chronic venous insufficiencies, no surgery. Leg, long saphenous vein, no stripping is done, it is only up to the thigh if it is required. Even that is not being done nowadays. Posterior arch vein, always evaluate. Routine, Trendelenburg surgery, never do it. If it is required, do it. Venous ulcers history of ulcers must be there before taking up forceps, subfacial endoscopic perforator surgery. Venogram is not done in the majority. Those days we were doing venography. Venography is not done. So ultimately, what really is the cause? The cause is the valves, valve myome. If you operate inappropriate thigh, he walks like a duck. Thank you.
Thank you, sir, for another wonderful lecture with recent advances. And anybody with a question to Professor Sivakumar? Any question or comment? Dr. Iman?
Hello, sir.
Yes.
Yes, sir. I just have a question, a very quick question. I'd like to ask about any measures can be done for DVT before recanalization occurs, so to prevent the chronic venous insufficiency later on?
If you mean by filters and all that?
What?
Use of filters.
Okay.
What do you think?
No, I mean
He
before
says
recanalization can...
before the recanalization occurs, anyway we can treat DVT and prevent venous insufficiency. Maybe some local measures she's talking about, sir.
See, need to have a compression bandage and this thing for the next 6 months before recanalization occurs. So a complete recanalization of the process takes about 6 months. 6 months you might need a conservative line of management, and till that time I don't think it is wise to operate for a TVI.
Okay, thank you.
Any other question to sir? There are no questions. Thank you, sir. Thanks for a wonderful lecture. Then we'll see you again coming week.
Thank you.
Thanks.